Dear Chairman, dear colleagues, thank you for the opportunity to present the results of our work to you. Thank you so much for invitation. I have nothing to disclose. The significance of the problem of endometriosis in adolescence is accounted for by the following. Endometriosis frequently manifests itself in adolescence, though the exact prevalence is very underestimated because 2/3 of girls during diagnostic laparoscopy reveal endometriosis. Though early diagnosis is a great challenge, and on average it takes from 5 to 10 years from the symptoms onset to diagnosis. And endometriosis adolescents expect help 3 times longer than adult women. The difficulty of diagnosis is also determined by non-specific clinical picture, lack of non-invasive tests, and the difficulty to detect endometriosis using imaging data, because tiny implants from 2 to 3 millimeters in diameter usually is below diagnostic efficiency and are commonly not visualized. So the aim of the present study was to compare the clinical features, instrumental diagnostics, surgical and histological peculiarities in adolescent patients in order to improve early diagnosis. A case control study was conducted. We included 90 girls with peritoneal endometriosis in the main group, and the control group consisted of 44 healthy girls with regular menses without dysmenorrhea. We enrolled in the study only girls with confirmed peritoneal endometriosis during diagnostic laparoscopy, which we conducted only in cases of severe or moderate dysmenorrhea with insufficiency of empirical treatment, even in negative MRI or ultrasound imaging, but with persistent of clinical picture. So the results, the main group usually was characterized with heredity of endometriosis or dysmenorrhea in close relatives. The age of menarche was earlier. The majority of girls also were characterized with blood spotting in most of cases in the middle of the cycle or close before menses, and more frequently the character of menstruation was heavy or irregular. And also the multivariate analysis confirmed heredity and dysmenorrhea from menarche as significant risk factors of endometriosis in adolescents. The main complaint was dysmenorrhea and pelvic pain. Usually the onset of dysmenorrhea was from the first menstruation or a year and a half after menstruation, and the majority of girls experienced pelvic pain at the beginning of the cycle or even every day. The severity of dysmenorrhea was moderate to severe, up to 7 to 8 scores on a visual analog scale, and the multivariate analysis revealed the significance of high scores on a visual analog scale in predicting of peritoneal endometriosis during laparoscopy. Besides, about 30% of girls showed gastrointestinal symptoms and urinary symptoms, which are less common for adolescents with endometriosis. The hormonal profile revealed higher levels of LH, prolactin, estradiol, and also oncomarker in the main group, and the higher LH level was also a risk factor for endometriosis in the girls. When we compared MRI signs in predicting peritoneal endometriosis in adolescents, we revealed the most essential which are listed here in the table. It is signs of sacrouterine ligaments involvement, like thickening or flattering of ligaments, also hyperintense foci, heterogeneity or signs of endometriosis in pelvic tissue, exactly paravariant, parametric or paracervical tissue, and also thickening of tissue of Douglas space, which were highly sensitive in diagnosing of peritoneal endometriosis. But according to ultrasound, it was possible to suspect only 3% of cases of peritoneal endometriosis in adolescents. When we use only MRI signs, we can predict endometriosis in about 80% of cases. When we use combined signs of MRI and persistent dysmenorrhea, we can predict peritoneal endometriosis in almost 85% of cases in adolescents. Here we also show these MRI signs on imaging. When we compare localization of endometriosic foci according to MRI and laparoscopy, it was showed that less than in half of the percent of cases we can predict, according to MRI, the compartments, exact compartments on uterosacral ligaments and the pouch of Douglas space. The results always matched for retrograde cervical area, but even in the cases of negative MRI results, in persistent clinical complaints, we can confirm endometriosis during laparoscopy. In majority of girls, laparoscopy reveals the first stage of endometriosis according to Revised American Society for Reproductive Medicine score. The second stage was almost in third part of patients, and the third stage was even less. The majority of girls showed transparent foci and white foci, and third part of girls black and red foci. Red lesions were observed more likely at a more severe stage of the disease. Transparent lesions were associated with higher VAS score, and white foci were correlated with prominent vasculature according to histological picture. So the results of our work are formulated in conclusions. Family history of endometriosis and dysmenorrhea from menarche increased the risks of peritoneal endometriosis in girls significantly higher, 5 to 20 times higher. The main endometriosis-associated complaints in adolescents are moderate to severe dysmenorrhea, decreased everyday activity, gastrointestinal and urinary symptoms, and mid-cycle spotting. Persistent dysmenorrhea and VAS score show high diagnostic significance for peritoneal endometriosis in adolescents. Patients with peritoneal endometriosis have higher plasma levels of luteinizing hormone, prolactin, estradiol, and CA125 for each. It was a significant score. Ultrasonography has low diagnostic potential for peritoneal endometriosis in adolescents. And MRI signs were show high significance for peritoneal endometriosis in adolescents, and this include heterogeneity of paravariant parametral tissue or hyperintense foci of the tissue and the punch of Douglas. The positive MRI signs provide 75% of diagnostic accuracy on their own. In combination with persistent dysmenorrhea, we have high diagnostic accuracy for peritoneal endometriosis detection in adolescents, about 80%. The majority of adolescents with peritoneal endometriosis had first stage of the disease, followed by the second stage and the third stage in less % of cases. Peritoneal lesions were found predominantly in uterosacral ligaments and punch of Douglas. Clear vesicle, red and white foci correlated with WASH score and pain intensity. The stage of the disease and the degree of vascularization respectively. So the main goal today, as it seems for us, is to diagnose endometriosis in adolescents as soon as possible at the age of manifestation, to have a high prognosis of treatment and less severe stages of the disease. Thank you for your attention.
Dear colleagues and friends, amenorrhea is the constant feature of anorexia nervosa caused by sharp metabolism reduction of gonadotropins as compared with prepubertal level, but its exact mechanism is unknown. There are 4 stages in dynamics of anorexia nervosa: primary, initial, anorectic, cachectic, and reduction. Aim of our research was to develop a method of forecasting of menstrual function restoration at patients at the stage of anorexia nervosa reduction. Objectives. 2 groups of patients, girls aged between 15 and 16, were investigated. Basic group, 89 anorexia nervosa diagnosed patients at the anorectic stage with a body mass index 15.3. Control group, 20 healthy adolescent girls with the body mass index 20.3. The retrospective analysis of menstrual counts was carried out. On the basis of it, the basic group has been divided into subgroups depending on a disease outcome. First A patients with proceeding amenorrhea, 42 persons, and first B patients with restored menstrual cycle, 47 persons. Treatment in both subgroups was identical. Measuring of serum leptin by ELISA body mass index research and leptin body mass index ratio at the first visit in 3 and in 6 months after treatment starting was carried out. The leptin level in B subgroup was 26 nanogram on milliliter and in first day subgroup 13 nanogram on milliliter in 3 months after starting of treatment. The analysis of leptin secretion at patients of B subgroup revealed that in the first time interval, the rate of increasing of leptin level exceeded the similar indicator of first A subgroup in 3.5 times. Leptin level in first B subgroup exceeded the basic level in 6 times, and in first A subgroup only in 1.5 times, and without having reached average values of control group at the final research. No one of the research periods of leptin value and leptin body mass index ratio of A subgroup did not come nearer to indicators of control group and were below values of first B subgroup. In our opinion, it testified about relative hypoleptinemia at patients of A subgroup since the stage of anorexia reduction. Research of leptin body mass index ratio rates increase has revealed essential distinction in 2 subgroups. At patients of A subgroup in the first period of research, the given indicator was lower than in first B subgroup in 4 times, and at the end of research in 5 times, and below values of control group in 2 times, thus without differing from the initial level. Absence of the dynamics of leptin body mass index ratio within 3 months from starting of treatment, despite body mass index increase, can be used as criterion of an efficiency of treatment estimation and the adverse forecast of restoration of menstrual function. On the basis of the spent comparative analysis of leptin levels in 2 investigated groups, at the stage of anorexia nervosa reduction after weight restoration but with proceeding amenorrhea, we have established the diagnostic thresholds for leptin level and the leptin body mass index ratio. For leptin cutoff 23.5 nanogram on milliliter, for leptin body mass index ratio cutoff 0.7. AUC 0.72 has allowed to estimate the given model as a good. Forecasting method of menstrual function restoration, increase of leptin level at the stage of anorexia nervosa reduction in 5.7 times from leptin level at anorectic stage within no more than 3 months, exceeding the diagnostic threshold of 23.5 nanogram per milliliter. Set no less than 3 units of body mass index for 3 months with approach of its values during menarche. Increase of leptin body mass index ratio in 4 times for 3 months of the starting treatment on anorectic stage, exceeding a diagnostic threshold leptin body mass index of 0.8. The research proves the necessity of inclusion for algorithm on conducting patients with anorexia nervosa leptin level and body mass index research at the first visit and in 3 and in 6 months from start of treatment. At proceeding amenorrhea and presence of the criteria defining the adverse for a post-menstrual function restoration in 3 months from starting treatment, at achievement by the patient of the set weight and in the presence of ultrasonic signs, uterus hypoplasia and absence of dynamics of follicle growth, necessity of hormone replacement therapy is proved. Necessity and timeliness of hormonal therapy is caused by a fast decreasing of mineral bone density and progressing uterus hypoplasia with hypoestrogenia that can lead to irreversibility of defeat of reproductive axis. Thank you for your attention. Dear colleague, I would like to present you the report which is called Investigation of Immunoendocrine Disorders in Adolescent Girls with Anorexia Nervosa. Anorexia nervosa, according to the International Classification of Diseases, is a disorder characterized by deliberate weight loss induced and sustained by the patient himself. There are 4 stages and dynamics of anorexia nervosa: primary, initial, anorectic, acectic, and stage of anorexia nervosa reduction. Amenorrhea is the constant feature of anorexia nervosa caused by the critical gonadotropin decrease as compared with prepubertal level. Aim of our research was to investigate immunoendocrine disorders in adolescent girls with anorexia nervosa to optimize the treatment tactics of this category of patients. Subjects. 3 groups of girls aged between 15 and 16 were investigated. Basic group, 59 girls with diagnosed anorexia nervosa and body mass index equals to 15.3. Comparison group, 53 patients with oligomenorrhea and low body mass index equals to 15.7 without anorexia nervosa. And control, 20 healthy adolescent girls with body mass index equals to 20.3. Methods: measuring of serum insulin, leptin, uropeptide Y, tumor necrosis factor alpha, protein binding insulin-like growth factor 1, gonadotropins, sex steroid by ELISA. Results. The analysis of hormonal indicators has revealed that the main characteristics of reproductive axis disorder at the anorectic stage is hypogonadotropic hypogonadism, activation of hypothalamo-pituitary-adrenal axis, and thyroid status disorder in the form of the secondary hypothyroidism caused by the dysfunction of hypothalamo-pituitary system. Leptin plays one of the most important roles in the maintenance of energy homeostasis. To determine the role of leptin in the development of amenorrhea during anorexia nervosa, we have investigated levels of leptin and neuropeptide Y. At the anorectic stage, leptin levels were 4.5 times lower than those in girls with a similar body mass deficiency and oligomenorrhea without anorexia nervosa. Hypothalamic or exogenic neuropeptide Y is the antagonist of leptin. There is an opinion that neuropeptide Y participates in regulating the reproductive function by means of stimulating gonadotropin-releasing hormone emission. At anorectic stage, leptin levels were lower than those of those with oligomenorrhea and body mass deficiency. That's why neuropeptide Y level at anorectic stage might increase the indices of comparison group, but it was not different in both groups. We suppose this phenomenon denotes the formation of the resistance to low leptin level at anorectic stage. The highest growth hormone levels were revealed at the anorectic stage that together with the minimum values of insulin-like growth factor 1 and index of free insulin-like growth factor 1 compared to the comparison group and control indices evidenced about the formation of somatotropin resistance. The role of growth hormone and pathogenesis of absolute hypoleptinemia and hypogonadotropism at anorectic stage is proved by the reverse correlation between growth hormone and leptin, growth hormone and follicle stimulating hormone. One of the specific components of the established metabolic disorders at anorectic stage was marked hypoinsulinism. The relative hyperinsulinism in comparison group points out at the specificity of this feature. The reason of hypoinsulinism at anorectic stage, along with the starvation, was the increase of plasma concentration of circulating insulin antagonist, growth hormone and TNF-alpha, that is confirmed by results of correlation analysis. The presented results permit to characterize the neuroendocrine metabolic disorders of the reproductive function regulation at anorectic stage of anorexia nervosa. Absolute hypoleptinemia, inadequately low NPY secretion denoting resistance to the low leptin levels, somatotropin resistance, hypoinsulinism as a consequence of starvation, and sharp counterinsular effect of growth hormone and TNF-alpha, hypogonadotropic hypogonadism, and thyroid status disorder in the form of the secondary hypothyroidism caused by the dysfunction of hypothalamic pituitary axis. Thank you for your attention.